All right, everyone. I think we're going to go ahead and get started. Still a number of people joining, but by the time we get through introductions and bios and such, we should be good to start. So my name is Scott Forsgren, and I'll be your moderator for tonight's event, which is a collaboration between IGeneX and Beyond Balance. And I'm excited to be here with you this evening as Dr. Joseph Burrascano and Susan McCamish present on tick-borne infections, clinical diagnosis, and botanical management. At the very end of the webinar, as time allows, we will attempt to respond to any questions that you may have. So you can submit those through the Zoom Q&A feature. We'll try to get to as many as we can. We will not be using chat for the session today, and all attendees are muted. So please submit your questions and we will attempt to respond to those shortly. The webinar is being recorded. It will be available along with the slides on the IGeneX website later this week and also on the Beyond Balance website shortly. Dr. Joseph Burrascano, he saw many patients with seemingly mysterious conditions in the 1980s. At that time, he was collaborating with key colleagues, including Alan MacDonald, Willy Bergdorfer, Bernard Berger, and many others, to work out the clinical details of Lyme disease, its presentation, laboratory features and diagnosis, and the very earliest meaningful studies on treatment. The culmination of this body of work is his now classic monograph, Diagnostic Hints and Treatment Guidelines on Lyme disease. It has been suggested that this work formed the basis of the modern, currently accepted view of Lyme and related tick-borne diseases, including how difficult it can be to diagnose and treat, and the wide spectrum of potential presentations that we're going to hear more about. He was a founding member and director of both the International Lyme and Associated Diseases Society, or ILADS, and its educational arm, the International Lyme and Associated Diseases Educational Foundation. He did close his practice several years ago. He began to work in the biotech arena as a research project analyst and project manager, and he is a consultant for IGeneX. And he's incredible, so we're happy to have him. Susan McCamish is a certified traditional naturopath, nutritional consultant, and herbalist who created the Beyond Balance line of products that are used today by practitioners in support of their patients or clients with complex chronic illnesses. The Beyond Balance line really was the result of her son's own health journey, being in a wheelchair at age 10 to discovering that he was dealing with Lyme disease, with mold illness. She then created a few herbal formulations to support his recovery. Word of mouth happened, and that ultimately became Beyond Balance. Fortunately, today at, I believe, 26, he's doing very, very well. Susan has researched and developed natural health products for over 30 years, and Beyond Balance now has a line of over 50 products that are primarily used to support detoxification, to provide the body with microbial support, and to enhance the body's ability to heal. Susan is also the founder of the Forum for Integrative Medicine, which hosts an annual conference for healthcare practitioners. And again, their talk today is Tick-Borne Infections, Clinical Diagnosis, and Botanical Management. It's an honor for me to moderate this event with them and to have both of them here. Thank you so much, and you may begin.
Okay, thank you, Scott. Thank you, everyone, for joining us. Tonight, I'm going to focus on the laboratory and clinical diagnosis of the tick-borne diseases. As a prelude to then Susan speaking about the actual management using her botanical skills, which I really rely on myself as an aside. Okay, let me have the next slide, Scott. We have a disclaimer, as you can read. I guess we can go to the next. So the key that I want to start with is that, we talk about tick-borne diseases, people say Lyme disease. Well, what actually is Lyme disease? Is it Borrelia burgdorferi, or is it the syndrome of Lyme that includes often many, many co-infections and even opportunists? As you can see from the map, these colored squares represent counties in which IGeneX found positive tests. So this is not some vague CDC survey of animals or ticks or whatever. This is actual positive tests by the foremost testing lab in the tick-borne disease arena. So you see these infections are widespread and they overlap. And just because the state shows blank, it doesn't mean it's not necessarily there, but maybe just didn't have a client from that state. Next one slide, Scott. So actually, it's more than just a theory and a map dot. These are actual results. In 2018, a poster was presented by IGeneX at one of the Lyme meetings, where they actually reported on a survey of over 10,000 of their positive samples. They found 37%, a little over 37%, were positive for Babesia, 32% for Lyme Borrelia, almost 28% for relapsing fever Borrelia. Also, there's Bartonella, Anaplasma, rickettsias, as well as Ehrlichias. Most importantly, though, 40% had 2 pathogens positive, 15% had 3, almost 5% had 4, and some even had 5 pathogens found in their testing. Next. Now, this is a very, very important slide I want to spend some time on. On the left column, you see Borrelia burgdorferi, in other words, the Lyme agent. On the other column is tick-borne relapsing fever, which is a really important topic we're going to go over in a little bit of detail. So starting with the Lyme Borrelia. When Lyme was first discovered to be an infection, it was because Willy Burgdorfer came to an island off of New York State, Shelter Island, collected ticks, and in the tick he found a spirochete. And that was eventually named after him, Borrelia burgdorferi. That one spirochete that he found that came from a tick from an island off of New York was said to be the type strain for Lyme. They use that as the basis for saying, right, this is the standard Lyme. We're going to use this as our standard. And from that became the testing. So this same strain, Borrelia burgdorferi, it's called strain B31, had formed the basis of the testing for Lyme disease back in the day. Strangely enough, and unfortunately, this is the very same strain that is used by our government to define Lyme disease. So if you have a CDC-based test or an FDA-approved test for Lyme disease, it's all based on this one strain, B31. It's called Borrelia burgdorferi sensu stricto. The problem is, number one, it's a strain that came from a tick, not a human being. Number two, it came from an island off of New York State, which probably doesn't represent what other Borrelia are around the country. Third thing is it's a lab strain. It's kept in culture in the lab. And over time, Borrelia change in culture. They lose pathogenicity, their genetics change, and so forth. So over time, this non-human strain became even more atypical and really does not represent the kind of things that clinicians are seeing. So you see in that same left column, there are a number of other names of Borrelia, burgdorferi 297, californiensis, and so forth. This group, as a totality, are called Borrelia burgdorferi sensu lato. So again, the B31 sensu stricto, and the whole group is called sensu lato. Now, the reason why B31 is in red is because, again, that's the one strain of one species, tick strain, that is used for all the testing that you get from FDA-approved testing, from the big box labs, from your hospitals. But all the others are clinically significant. And IGeneX does test, all the IGeneX Lyme testing will test all these different species and even more. And that's what sets IGeneX apart, and which is why Lyme-literate physicians insist upon IGeneX whenever possible, because it does represent the reality of Lyme in our country. Now, the next column, tick-borne relapsing fever. Right? Why are we talking about relapsing fever in a Lyme lecture? Well, it turns out that they found, I'll show you a slide on this next, is that people who came to the doctor with all the signs and symptoms of Lyme, and the clinician agreed with them that this is Lyme disease, and they tested them, and guess what? Their Lyme test was negative. Okay, seronegative Lyme. Well, it turned out these patients had Borrelia from the relapsing fever group, and they presented exactly like Lyme disease. So if you order a Lyme disease test, you're not going to get tested for relapsing fever, yet these are causing Lyme-type symptoms in a great number of patients. Okay, so in the relapsing fever column, the two that are in red, Hermesii and Miyamotoi, are the only two that you can get tested for at the large big box labs and hospitals, and you have to order them separately. But all of them, the whole column, and even more, are tested for by the IGeneX panel of tests. So this is a really important thing to understand and remember as we go through the presentation. Next one. So Lyme has what I call the cardinal clinical features. It's multi-system, migratory, and cyclic. This is how you make the clinical diagnosis. Multi-system means it's not just a sore knee. It's joints, nervous system, central nervous system, peripheral nervous system. It can involve the skin, the heart, the GI tract. And there are many non-specific symptoms as well: fatigue, headache, the cognitive difficulties, malaise, and so forth. So it's multi-system. Second thing is that it's migratory. The symptom location and the organ that's affected will vary over time in someone who's not treated. So, for example, you can have a sore joint for a period of weeks to months that gradually seems to get better, but then a different joint starts to bother you. And then you start to get nervous system problems, tingles, numbness, unsteadiness, a Bell's palsy, which may go away on its own. And then another joint starts to bother you. Then cognitive things happen. So it's something that migrates. And it's known to be the only infection that will cause a migratory neuropathy and a migratory arthritis. So that's a really important thing. And this is why clinically we recommend you always have your patients keep a diary. And the final thing is that it's cyclic. If you have this diary, track symptoms day by day, you'll see that there's a 4-week cycle in Lyme. In other words, there's one really bad week with a lot of symptoms that gradually seems to subside and get a little bit less intense. But 4 weeks later, it gets bad again. It's a classic 4-week cycle. In relapsing fever, the cycle may be a little bit shorter. But again, if you have a multi-system illness that migrates and cycles, that's Lyme disease. All right, you can go to the next. The reason why I want to talk about relapsing fever and emphasize it is, as you can see from the map, number one, the locations overlap with Lyme. Second thing is that if you read the textbooks on relapsing fever, you're going to get the wrong impression. Textbook description is that you get an acute illness with a high fever, you're severely sick, you're sick for several days, but it ends with what's called a crisis, sweats, weakness, and you really feel wiped out. But then over the next several days, you start feeling better and you almost feel back to normal. But by 5 to 7 days, bam, it hits you again and you're sick. That's why it got the name relapsing fever. However, as I mentioned, in a large number of patients, this does not happen. This is not the way it presents. It presents almost identically to Lyme disease. Patients get tested for Lyme. They don't get tested for relapsing fever if the doctor and clinician does not know about this. Next one. Now, how about statistics? Study was done, 543 patients who came to the clinician with Lyme symptoms, and the patient and the clinician suspected Lyme disease. Well, in fact, by testing with IGeneX, 32% indeed had antibodies for Lyme, but 22% did not have Lyme antibodies, had relapsing fever antibodies, and 7% had actually both. So again, these all resembled Lyme patients, not relapsing fever patients. So the conclusion from all of this is that if you have a patient presents with Lyme disease, you must test them for relapsing fever as well as for Lyme disease. And you also must, as you know from that first slide with all the columns, you must not test for just B. burgdorferi B31 with some big box lab. You need to use a lab like IGeneX that tests for all the clinically important strains and species. Next. Now, what about the seronegative patient? Maybe the seronegativity is not because they have a weak case of Lyme or it's a bad lab, but maybe it's because you're testing for the wrong species. The point is that none of the big box commercial laboratories, those that use test kits, those that are FDA approved kits, none of them, whether they're an IFA, ELISA, or even a Western blot, PCRs, T-cell tests, none of them have been validated for all the different Lyme Borrelia, the Borrelia burgdorferi, sensolato, that whole column, and none of them have been validated for any relapsing fever. So that's, again, why you may have a seronegative test. And when it comes to relapsing fever, the testing for that has only been validated against those 2 strains I showed you in red, Hermsii and Miyamotoi, and each one has to be ordered separately. So it's always been recommended that, again, if you have someone presenting with Lyme-like symptoms, you test for both Lyme and sensolato, the whole column, and relapsing fever. And just, I'm getting ahead of myself, but in testing, the immunoblots that are created by IGeneX will test all of those that I mentioned. They also have a culture test we'll talk about that diagnoses based on the genus. So they'll find Borrelia and they'll help to let you know which one it is. So it's much more inclusive and much more broad in scope. Next one. So these are lab tests that are out there. I went through this quickly before, but let me go through them a little bit more. The IFA and ELISA, these are the tests that have been around. Actually, the IFA was developed in the early 1980s when I was just starting practice. And we found that they're notoriously insensitive. And several different clinical series have been published where they found the sensitivity around 50%. In other words, you're missing half the cases if you rely on this to help you support the diagnosis. In addition, you can find false positives, viral infections, autoimmune diseases, other spirochetes, including even oral flora from gum disease, can give you a false positive. When these tests are done, again, they're looking for that one single species, that lab strain. And it's just not recommended. Don't waste your time, the patient's blood or money doing these tests. Now, the Western blot has always been thought to be a little bit better test. And yeah, it is a little bit better. The sensitivity is a little bit higher than in ELISA, but also false positives are possible. It's only one species, and again, usually lab strain B31. IGeneX went ahead and developed an immunoblot, which is a completely different technology. Even though it sounds blot in the name, it's really not the same thing as a Western blot at all. They found on validation studies that, and some have been published, sensitivity is between 93 and 99%. The specificity is between 97 and 100% based on which study they look for, and is capable of picking up multiple species. IGeneX also offers a T-cell stimulation assay. The reason why that's important is because immunoblots and other serologies measure the B cell response. As we all know, a number of Lyme patients have weakened immune systems for a variety of reasons, and you may not get a positive B cell response. So you can then do a T cell based assay that's called an IGeneX spot, and it looks for reactivity based on whether someone's been exposed. Now, the beauty of these tests is that you can do an immunoblot and a T cell test on the same patient, and it gives you a picture of the immune response. If someone has a strong T cell response and an absent or very weak B cell response, you know right away there's proof that there's something wrong with their immune system. Now, the big news also with IGeneX, they've developed a culture. They're the only commercially available culture for tick-borne diseases available around the world. They have found that even though it's a direct test, the sensitivity is really very high, and I'll go through the numbers in a minute. And the specificity in their studies has been 100%. And again, it's multi-species. Next slide. The immunoblot itself, what makes it different is that it doesn't use lab strains that are sonicated and blotted out on tissue on filter paper. They use recombinant technology to use specific antigens in their system and print it out onto their test system. So it's very, very precise and accurate. And I'll give you the numbers. This is the only test that has been able to detect early Lyme disease with a sensitivity of 93%. It's game changing. You know, early Lyme has always been said, someone comes in with an EM rash, early Lyme, summer flu. Don't even waste your time testing because the tests are not accurate. And CDC's own studies show about a 20% pickup rate in early Lyme. However, using the same samples from CDC, they found a combined sensitivity of 93% in early Lyme disease. So someone comes in with an atypical rash or some weird summer flu after being tick exposed. Now you have a test with a sensitivity of 93% that can help you figure it out. So it's game changing. In established cases, the sensitivity has been demonstrated to be as high as 100% in some series. It's never been less than 90% in the different series I've seen. So it's really, really a sensitive test. When it comes to specificity, lack of false positives, the validation studies with unknowns showed 97 to 100% specificity. In other words, it's rare to get a false positive. Now, another interesting thing, how many times have you seen a Lyme patient get a serology done and they've had ongoing long-standing Lyme and they have a positive IgM response? IgM is thought to be an early responder to an infection that appears within a couple of weeks, persists for maybe a month, and then gradually goes away and stays away and then becomes IgG. It's also been found that with testing like with ELISAs and Western blots, a positive IgM late disease can be a false positive because in those low quality tests, some viral infections and other immune things, as I mentioned before, can give a false positive in IgM. That's not the case with an immunoblot. They found that even in late disease, the IgM, if positive, is 97% specific. So you can no longer dismiss a positive late IgM and say, well, that's a false positive, I don't believe it. Here it's got 97% chance of being a real result. And finally, it's multi-species capable. It can detect all the clinically relevant Borrelia burgdorferi sensu-lato, the Lyme group. Okay, so basically it's so sensitive. If antibody is present, someone's immune system is strong enough to make antibody, you'll get a positive. Next. And for relapsing fever, the immunoblot, likewise, I put the tables up, but the bottom line is the sensitivity in this series of PCR positive patients. So, definitely they had the relapsing fever. They picked up every single one of them in late infections. Even early infections, they picked up 2/3 of them. And you see from the column on the right, the specificity was 98%. And they tested everything. They tested syphilis, rheumatoid arthritis, HIV, all the other tick-borne major diseases, fibromyalgia, mono. and endemic controls. So again, here specificity of 98%. And again, they're able to detect the major species in our country causing relapsing fever. Next. So the recommendation is you need to use a test that will detect the broadest range of species, not just that one lab strain. So in Lyme, it includes testing that whole first column, Borrelia burgdorferi, sensu-lato, and relapsing fever, likewise, multiple species. So you need to use a test or a series of tests that will do that. Now, the best way to pick these up is not to do one test, but to combine different methods, what's called a direct test, for example, a culture, and an indirect test that measures the antibody response. So that would be an immunoblot for the antibody response, and a culture that's what they call a CE-PCR. You can add the T cell response test if the B cell function is poor. If you're doing a biopsy, you can do the PCR on that, and now you can even culture it, which is even better. Often people go to orthopedists to get a synovial biopsy done, or they get fluid taken out of the joint. When mothers give birth who have Lyme and they give birth, it's always recommended you have the placenta tested by placental PCR or now culture. And finally, I didn't go into this in detail, but IGeneX also offers antigen testing of the urine. It's an old test that's been around a long, long, long time. I've always used it. I find it really helpful when it's hard to draw blood on someone, especially for newborns where they don't have much blood to give and they don't like being stuck. And just as an aside, if I had a mom who gave birth to a baby, the mom had Lyme, so I'd monitor the baby not by blood testing because that would be inappropriate, but by urine testing because it's a direct antigen test, very easy to collect baby urine. And we do it once a month for the first 6 to 12 months of their life. Next. We'll talk about Bartonella next. It's extremely common in Lyme patients. It's very complicated now because there are dozens and dozens of species known to exist. And therefore, you really have to, especially in this disease, have a test or a series of tests that can look at these different species. Another thing about Bartonella is, if you didn't know, it's a major builder of biofilms. Not only does that make the Bartonella a more difficult infection to eradicate, it also makes it more difficult to detect because it can hide in kind of a stealth fashion. The other reason why it's so common is because it's not just from tick bites, although tick bites can transmit it, that's been proven now and published, but you can get it from other vectors, fleas, mosquitoes, biting flies, mites, even red ants I recently discovered, and of course animal bites and scratches. That's why it was originally called cat scratch disease. Veterinary workers, animal workers are known to be at risk. Needle sticks for the same reason, and just like with Lyme disease, it can be passed from mother to baby. It's worldwide in distribution, and I've read many articles where they've detected it even far above the Arctic Circle in Canada, Alaska, you see on the map. So it's really a big, big problem. Next. Clinically, this is a little bit different from Lyme. Yes, they're the general symptoms, but there are certain things that make you think about Bartonella. The main thing is that it's a strong irritant and stimulant to the central nervous system. So you have a patient who, for the first time in their life, develops anxiety, true panic attacks, insomnia, tremors. They have seizures, or what some call pseudo seizures. It can cause them to have an unsteady gait. The panic attacks can evolve into rage attacks with even antisocial behavior, and that's been published by Dr. Bransfield. It can also cause mood changes, depression, can cause hallucinations. It's been linked to schizophrenia in some cases and even dementia. So it really involves the central nervous system in a way that Lyme does not, in terms of causing the excess stimulation, as though someone's being overdosed on some stimulant or caffeine. Another thing about Bartonella, it's classically known to involve the eye. It can involve basically infecting any layer of the eye, and in fact, it can cause artery and vein thromboses. So if there's someone who has tick-borne diseases with very prominent eye symptoms, think of Bartonella. Another thing differentiates it. You generally don't see swollen lymph glands in Lyme disease, but you do with Bartonella. And I actually had a case I talk about often, a young man who was thought to have lymphoma, was ready to get chemotherapy. And long story short, it was Bartonella. Treated it, the glands went away. He did not have a lymphoma. With Lyme disease, you have inflammation of the synovial lining, the tendon, the lining of the joints. With Bartonella, it's a little bit different. The joints can hurt, but it's not because of thickened synovia. It's because it involves more the tendons and the ligaments. Also, because of that, there can be subcutaneous nodules that are tender along the ligaments and fascia. Sore bottoms of the feet, your soles are sore. People often hobble around when they first get up in the morning. And the joints, when they're painful, because it's not the synovium, it's more the ligaments. So you don't find big effusions and large swelling. So if you find, again, very painful joints, look to see where it's coming from. If it's really ligaments and tendons, think more Bartonella than Lyme Borrelia. People know that Bartonella can cause these strange skin marks. They look like stretch marks, but they're really not. Then they called them Bartonella tracks. Now they have other names for it. But basically, they are red, not silver-like stretch marks. They do not follow skin planes. They're sites of active infection, and they're pretty characteristic. Can also cause what look like scabbed over pimples. That's called bacillary angiomatosis, and patients can have both. I've seen that. The other thing that makes Bartonella very unique is that it can and often does involve infecting the GI tract. If it's the upper GI tract, it can mimic H. pylori with a really resistant case of gastritis. The lower GI tract, it can inflame the lymph nodes around the small intestine, where there's nonspecific diffuse abdominal pain, and that's mesenteric lymphadenitis. And bad cases can involve the liver as well. Next. Testing for Bartonella, the indirect tests. These are serologies. You can get IFAs. That's basically what the big labs offer. That, again, is very old technology, only designed to detect one species. Just like with Lyme, there's false negatives, some false positives. You can get now an immunoblot from IGeneX. It's much more sensitive, designed to detect multiple species. Several series of validation, they found that culture positive samples, 100% of them were immunoblot positive, so that was a good correlation there. They did a specificity study of patients who had other tick-borne diseases, but not Bartonella, and the specificity in that group was 100%. So that's really, again, a good test to get. And just like with Lyme, you can get a T-cell stimulation assay. Because it's genus level, you can pick up more than just cat scratch disease. You have a good chance of picking up some of the atypicals as well. Next. The direct test for Bartonella, the one called FISH is a fluorescent in situ hybridization. That basically is a blood slide. Instead of staining it with a dye, it's stained with a probe for the RNA specifically for Bartonella. And they link it to fluorescence, so it shows it very, very well. So it's definitely a direct test. And the thing that's special about this, very important, is that it can detect organisms, including Bartonella, that are hidden in biofilms. So it's one way to unstealth a stealth organism. They did an inclusivity study. They were able to detect all the different Bartonella species in the panel. There are actually 6 plus an atypical. They picked all of them up. And they tested patients who had other tick-borne diseases other than Lyme. Other than Bartonella, and there's no cross-reactivity with any of them, and not even with malaria or trypanosomes. They also offer now a culture for Bartonella, very, very exciting. They use, I didn't get into the detail, but they take the blood, they put it in an incubator for 2 whole weeks, and then as they assess the growth, they actually use a very specially developed PCR to confirm what's actually there. So they call it a CE PCR, culture enhanced PCR, but really it's more culture than a PCR. The PCR is just a way to validate what's in there. But the PCR on the culture is a genus level, so it has a good chance of picking up all the different common species and also some of the atypical ones as well. Next. So the recommendations, because as you know, Bartonella is very hard to detect. It is a stealth organism. No one test is 100% sensitive, and many, many species and many biofilms. So what you need to do is combine multiple methods and use the best possible tests, the immunoblot and the FISH and the culture. You really need all 3 because there are cases of a positive immunoblot and the others negative. A positive culture, negative FISH, negative immunoblot, and all the ways have seen it. So you really, really need to do all 3 if you need to detect it. And again, if there's a B cell deficit, an immune deficiency, you add to that a T cell response assay from IGeneX. Next. Now, we talk about Babesia. It's a parasite, not a bacterium. It lives within the red cells, and in very heavy infections can be free swimming in the bloodstream. As you saw from the early slides, it's the most common co-infection in Lyme patients. What makes this different from Lyme Borrelia is that you can find fevers and really obvious sweats. The headache from Babesia is migraine-like and responds to migraine medications. That's as opposed to Lyme headaches, which are more in the back of the neck and the stiff, cracky, kind of a nuchal headache. Another thing about Babesia, there's a strange sense of shortness of breath. It's called air hunger. You can be short of breath just completely doing nothing, sitting, talking on the phone, and you start to lose air. Likewise, it can be a dry cough for no apparent reason. But because it's more of a parasite, profound fatigue is a big part of it. What it does also is it sludges the blood flow, and that causes poor blood flow through the brain, causing balance issues and cognitive dysfunction. That's probably also why you get air hunger and a cough. And the balance problem from Babesia is not vertigo. It's more of a tippy off balance feeling, like you're going to fall down the stairs when you go up. So it's a very different kind of a thing from vertigo. Other symptoms do overlap with Lyme, but one of the other things that's interesting, because they infect red cells, they actually can damage them. And over time, the damaged red cells lose their iron, gets excreted through the urine, and you become iron deficient. So if you find a patient who's chronically sick with an unexpected iron deficiency, think Babesia. It can be transmission by transfusion from mother to baby as well. In the United States, the main species are Microti and Duncani, but there's also MO1, that's a Missouri strain, Babesia divergens, Otocolii, and others. And even some very atypical strange things have been discovered by using the culture as well. Next. I want to talk about Babesia otocolii because there's a lot of talk about it. It's the most common strain of Babesia in deer. That's how it got its name. And actually, there have been case reports of Canadian patients published where they confirmed it was present. If you use IFA staining of the blood, not a very specific method, but still one you can use, some labs claim that they're finding otocolii using their IFAs. However, there was a series of not one or two, but 460 Babesia positive samples that had DNA sequencing, and not a single case of otocolii was found. So I don't know, is that a confusion about which primer sets are being used? Is otocolii really more a Duncani? It's just a different name. There's a lot of different takes on this. But if you do immunoblots on Babesia patients, you find that a lot of them have Microti, a lot of them have Duncani, and a lot of them have an atypical species that they can't actually identify, and maybe that's otocolii. So the jury's out on this, but otocolii will be picked up by the IGeneX testing. It just will not be named as otocolii. It'll be getting a test that says Babesia species positive. Next. Testing. You can do a blood smear. This is what's done in hospitals for acute cases. It only works the first week when the parasitemia is very highest. The limit of detection, how good of a test is it? Well, if you have 10% of your blood cells infected, you're going to find it. 1%, you may find it, but the limit is about 0.5%. So if 1 out of 200 cells are infected, that's the limit of sensitivity. You can get a FISH test from IGeneX for Babesia. And again, it uses RNA probes using fluorescent dyes. The sensitivity is hundreds of times better. The limit of detection is not 0.5%, it's 0.001%. It's much, much higher. And again, FISH testing can detect organisms in biofilm. And because it's genus level, you're going to get a lot of different species out of it. Babesia, you can get an immunoblot. It's much more sensitive than the standard IFAs that the big labs offer. Broad species coverage. The specificity in their testing has been 100%. You're not going to get a false positive. Again, you can get T-cell response assays, which is great if you have a B-cell deficient patient and if you want to do a survey of the immune response. And finally, culture. This is the first time you can get a commercial culture of Babesia from patients. It's a genus level test. They've picked up many different species, including some really strange ones you didn't expect ever to be found in humans, but that's been found. Next. So testing recommendations with Babesia, just like with Bartonella, it's very difficult to detect. No one test is 100% sensitive because these are parasites. They hide, they go into their own biofilms, and they're difficult. So besides that, a lot of different species are out there that were not previously expected to involve human illness, but they're out there. So we definitely recommend, as with Bartonella, you combine a direct and an indirect test, and you do as many tests as you can with a high sensitivity, like the immunoblot and the FISH and the culture. Again, B-cell testing, if there's a problem with that, you add the T-cell assay as well. Next one. We're going to finish with the Rickettsia family, and the reason why I bring it up, because labs are finding an increased incidence of all the Rickettsias. And if you ever look at tick surveys where they analyze what organisms are found in ticks, pretty much every single time they're going to mention Ricketsias, probably even more commonly than Borrelia, Bartonella, and the others. And the reason why it's so important is that acute infections can actually be fatal. And I've actually seen that happen. Not my patient, thank God, but unfortunately, young people can die from this. So it presents with an acute fever, headache, the kind of like a knife through the ice, different from a Lyme headache, different from a Babesia headache. And here the pain is in the muscles, not the joints and tendons, often associated with low white count, low platelet count, and sometimes elevated liver enzymes. So that's the tip off. If you get a rash, about 5% of the time with most of the others, but about 90% of the time with Rocky Mountain spotted fever, hence the name, it's a vasculitic rash, involves the palms and soles. And as a vasculitis, it's a red spot that if you press on it, it'll blanch. And as you let go, it'll refill from the central vein. And that's characteristic. So that's a good tip off for that one. Next. Testing, you can get IFAs. You can't get immunoblots for these at this point, but you can get cultures for Anaplasma, Ehrlichia, and for rickettsias. You just cannot get a culture for Rocky Mountain spotted fever. The government doesn't allow that unless you're a biosafety level 4 laboratory. Next one. Oh, Scott. Okay, here we go. I made this up quickly. I don't want to spend too much time on it because I want to turn this over to Susan, but you can look at this when you have time. But this is just like the clinical guide. For example, Lyme and Bartonella often have a gradual onset, whereas Babesia and rickettsias can be abrupt. Lyme has this 4-week cycle to it. Babesia may cycle every week or so, but not clearly. Lyme is joints, multi-system, migratory, and cyclic. Bartonella is soft tissues, lymphadenopathy, and this excitatory thing to the nervous system. Babesia is the air hunger, the cough, the tippy feeling, and the sweats and fevers and making everything else worse. And the rickettsias is a very acute onset. Some low platelets, white cell counts, and liver enzymes are tip-offs. Headache from Lyme is the back of the neck. You're stiff. People are shrugging all their shoulders. The headache from Bartonella is not very specific. One of the Babesia is band-like and migraine-like, responds to migraine medications. Rickettsias are really acute, like someone's putting a knife through your head. If you get a fever with Lyme, it's hard to detect. It's on the range of 99, 99.2, and it usually happens late in the afternoon. If Bartonella, same low-grade fever, usually happens early in the morning upon arising. Babesia can be anytime and can be high, as with the rickettsias. No sweats from Lyme, maybe some sweating from Bartonella. Babesia, drenching sweats, day sweats, night sweats, and acutely with rickettsias. If you're on Lyme treatment and you stop treatment too soon and someone's still infected, there will be a relapse. But because Lyme germs move slowly, the relapse takes time, measured in weeks. On the other hand, Bartonella is a much more quickly moving organism. And if someone's on treatment with antibiotics and they're stopped too soon and there's a relapse in a matter of a few days, say, oh, that can't be Lyme. Lyme doesn't move that quickly. Let's think Bartonella. Babesia, likewise, is a slow-moving parasite. It takes weeks to months for relapses to show. In fact, people have relapsed years later. And rickettsias, likewise, it's a gradual one. Next slide. So the testing guide, don't want to go through this too much, but you can look at it at your leisure. It talks about the different methods, the features, when to use, and accuracy. And basically, you don't use IFAs, ELISAs, and Western blots anymore. They've been replaced with immunoblots. You don't use PCRs anymore unless it's on a biopsy, but we do that now on culturing, and culture basically replaced all the PCRs. FISH is great, but it's only available for Bartonella and Babesia. And urine antigen capture is really good when you can't draw blood. All right, next one. As a lead into what Susan's going to talk about is that when someone's chronically sick with these really terrible infections, especially co-infect with several of them, the problem is that the body gets damaged. We call that the terrain. You have to correct the terrain, or the treatment will be less effective, more difficult to tolerate. Antibiotic-resistant bacteria that are called persisters, they've been described, it causes complex problems, treatment failures, multi-drug regimens are often needed. Treatment-resistant babesiosis is being found, more and more rickettsias and anaplasmas. Opportunists are also there. We have someone who's been beaten up by these tick-borne diseases, the immune system gets harmed. They start showing up with mycoplasma, chlamydia, reactivated viruses, yeast, and so forth. Next. So what you really, really, really need to do, and this is where Susan's work is so critically important, is that you need to resuscitate the patient before you start the antibiotics. And some people can't tolerate antibiotics and rely specifically on botanicals. So why is that? Well, chronic inflammatory diseases of any kind, they not only negatively impact metabolism, which directly hurts your immune system, it also impacts or inhibits detoxification. It blunts hormone responses, hurts the immune system. You get dysbiosis, mucosal inflammation, leaky gut, thick gut biofilms. It's been found that gut biofilms can harbor entrapped viruses, which can be released, and they all have to be addressed. So basically, you really need to do what I call a multifaceted approach: nutritional support, detoxification, immune support, manage inflammation, and target the infections. And that's our lead into Susan. Next slide. Here we go. Susan, are you on?
I am. Thank you so much. That was fantastic.
Oh, thank you. Take care.
Thank you. You too. So as Dr. Joe mentioned, botanicals can be really valuable in this discussion for a number of different reasons. So we're going to review some of that information. Herbs or botanicals are very high in balanced vitamins, minerals, amino acids, all kinds of nutritional components are contained within botanicals. They contain antioxidant content as well as nutritional content. They have tremendous corrective properties, which can be substantiated by, particularly with individual herbs, can be substantiated by studies. And the literature that really refers to them as having antimicrobial properties, antifungal, antiviral, antibacterial, vermifuge, or antiparasitic, as well as purgative. A singular herb has multifaceted applications. So when you combine herbs, they become highly synergistic so that you can use them in a combination or formula that can have some power behind it, which can be very, very helpful with particularly stealth infections. Herbs can be accepted by cells as fuel because botanicals or herbs are foods. And so they are very bioavailable in the body. Excuse me. Herbs support organ function, and they also, excuse me, limit need for large protocols. So in other words, it limits the need for multiple different forms of supplementation, whether it be in an herbal form or in a vitamin form, etc. So one of the things that I'm well known for stating, excuse me for just a moment, is that herbs are umbrella-like due to the fact that they have this synergistic capacity when you do work with a number of different herbs together. They really have some broad coverage in balancing microbial overgrowth. So they can have multiple uses in this type of combination. They support detoxification. They can support organ function as well as immune function, as Dr. Burrascano mentioned, as well as reducing inflammation. They assist in assimilation and absorption of nutrients, which is a wonderful property. You can actually, as you're working with some of the microbial overgrowths or some of the other issues that I just mentioned, you're also able to support the body in a way to offer healing properties and move the patient forward. So it can be really very, very helpful. Also, there are plant enzymes that are contained in many different herbs, which again makes them very bioavailable and useful. Many times we refer to the toxins that a lot of these organisms produce. They produce endo and exotoxins, as well as just that debility with the patient in regards to the fact that they really have a difficult time with detoxification. So this approach here is similar to the overflowing sink and tub and toilet, as the symptoms are really as a result not just of the infection, but also of toxicity, which comes about as a result of an imbalance in the body. We need to really reduce this by supporting detoxification as well as drainage before working with the existing microbial burden. Very, very important. It may include mycotoxins, heavy metals, pesticides, chemicals, many different types of toxins that really have overloaded the system and create symptoms that can be supported by reducing them. Approaches including slowing down that faucet, so reducing the antimicrobial by reducing that stress on the system, or opening the drains by supporting detoxification as well as drainage. And there's much support that is available for that. Let's see, any protocol. We really encourage any practitioner to support detox and drainage with any particular protocol. It is necessary at all times. So some of the support that we have in the Beyond Balance line, building that on the foundation of detoxification support, includes some of the items that are mentioned here. It optimizes outcomes, and that has been seen over and over again. As a starting point for some of the detoxification and drainage, you might use Toxie's Bind, which is a well-rounded binder for many of the mycotoxins, as well as Cogni's Detox, which is very supportive for those patients that have multiple sensitivities. Toxie's Bind and Toxie's can also be used in combination. Toxie's capsules are largely considered general support for detoxification, the detox pathways, as well as supporting organs as a result, as well as combining Toxie's GL, which was originally formulated to support cellular detoxification. So very, very helpful with some of these toxins. So regarding inflammation and immune modulation, this is so very important. Unfortunately, not only can the organisms themselves, whether they be parasitic or some of the microbial infections that we've spoken about today, can produce a tremendous amount of inflammation. The toxins alone can produce inflammation, so it really needs to be supported. GI inflammation is often an issue and can improve tolerance of protocols. So supporting the reduction of that systemic as well as GI inflammation is very, very helpful. Some of the products that we use in the line can be Cyflocom 2, which supports those that suffer from neuroinflammation, or GI inflammation support, as with MASTs, if the inflammation is driven by MCAS or histamine issues. Supporting the modulation of a hypervigilant immune system or autoimmune response, IM and Calm can be very, very helpful in this area, which can help to improve the protocol tolerance. So say, for instance, as Dr. Burrascano was mentioning, you may have multiple infections, and it can create that hypervigilant or upregulated immune system so that you have a tremendous amount of inflammation and the immune system itself is overactive. IM and Calm can help reduce that while also reducing an inflammatory burden, but you're able to continue with treatment of some of those infections. So it can be a win-win situation in trying to work with some of these tools that we do have. We do have a number of viral support formulas as well. This can be a place to start with some patients who have an excessive viral load. Many chronic viruses contribute to chronic illnesses, including many of the herpes viruses, as well as Epstein-Barr virus, cytomegalovirus, Coxsackie, and many others. Many of the symptoms of chronic illness may be as the result of underlying viral activation. Post-COVID, we really saw a tremendous amount of it, and it continues to be an issue. So it's something to certainly keep on our radar. But Beyond Balance has created several of these formulas: IMNV, IMNV2, V3, and V4, as well as other support to help with chronic viral activity. And again, these are support, not making a claim that they eradicate everything, but really support the body's ability to work with these viruses. Each formula has a specific purpose in terms of the types of viral support provided. We offer a lot of education to practitioners to help them to be familiar with some of these tools and what can be used. In many cases, sometimes that broad support is needed from more than one due to the fact, I say more than one formula, due to the fact that there are multiple viruses that people can be infected with it at one time. So we can use one or two of these formulas at the same time. For GI support, we do have specific support in this area as well to address dysbiosis as well as inflammation early on in a protocol with such products as IMNGI, IMNB, IMNB2, and Cyflicom-2. Some of these can be very helpful with conditions such as SIBO or CFO, which SIBO would deal with the GI dysbiosis from bacteria or bacterial overgrowth, small intestinal bacterial overgrowth, or F as in fungal overgrowth as well. And related conditions are common factors in those with chronic complex illnesses. It's very common to see GI issues. So this can really be very, very helpful. And since, over 70% of the immune system is found in the gut, this is really important for practitioners to be able to work with patients in improving their gut health. Very, very important. In some, the GI dysbiosis may be parasitic in nature and may consist of protozoal or other parasitic overgrowths. And for that reason, we have several different options. MCPZ that does support the body's natural ability to inhibit protozoal activity, as well as Pronan, Pyrazinamide, and Paralivier. Again, all for specific issues. And I think this is headed back to you.
Dr. B, are you on with us still? There he is.
There I am.
All right.
I have a delayed click. I press a button, I have to wait. Sorry about that. Anyway, I want to talk about persisters. What is a persister? It's been found that someone who has an infection with some of these tick-borne diseases, the antibiotics work to a point and then they stop. It's like the patient gets to a plateau. They found that even if they've been given an antibiotic that seemed to work in the test tube and should kill the germ, not all the bacteria die. And why? What they do is they shift into kind of a stationary phase, a hibernation phase. They call them persisters. And it turns out that antibiotics kill bacteria when they're growing. So if you're in a stationary hibernating phase, it's very difficult to find a treatment that will actually kill them. Trouble is that even though they might be hibernating, these organisms are still producing antigens and other biological products that can make you sick, activate the immune system, and keep you having symptoms. Turns out when you stop the antibiotics, the patients can, or the persisters can revert to active growth again and make you even more sick. So that's why so many people have problem getting over the infection. Now, one of the hints of how do you know if someone has a persister? Well, there's no real test for persister, but the literature shows something very interesting. Monica Embers is the researcher who does all the primate studies for the Lyme and other bacterial infections from ticks. And she found persisters in her primates. And in them, they were seronegative, but they had a culture that was positive or a PCR that was positive. So if you have a patient, and I've seen this also looking at the results, who has a positive culture, but they're seronegative even by an immunoglobulin negative, that's much more likely that they have persisters. Next. So there are different ways you can treat persisters. One is to use pharmaceutical regimens that are targeting these stationary phase and biofilm persisters. Very often persisters make biofilms, and that's where they hide. Now, these regimens that work are usually very, very complicated, using multiple antibiotics, many of which are toxic and need careful monitoring. using double, even quadruple doses of some of the more exotic antibiotics. So that's one option, and has been used by some. Another option is botanicals. There are now multiple published articles showing that botanicals have been demonstrated to not only kill the actively growing, but even to target the stationary phase and the biofilm phase of these persisters. So if these are used properly, these regimens may actually replace the need for some of these more toxic antibiotics. Now, there's always option 3 is use both. And very often the more advanced clinicians will use both because more is better as long as you don't make the patient sick. Next one. Back to Susan.
Okay, very good. Yeah. Yeah, it's very interesting. Some of the studies that you just referred to, very, very fascinating. And it's wonderful to see some of the efficacy that we are with those singular herbs. And as I mentioned, using a formula, you do get so much from that ability to have broad coverage, which is really fantastic. And I will say that there are many herbs that may not necessarily have been studied to this point in terms of application to Borrelia and other specific organisms, but there's really some promising information regarding multiple different types of bacterias, viruses, organisms of all different types, microbial included. So I'm sure that we'll be seeing a lot more down the road. Really very, very helpful. So regarding support for Borrelia and Bartonella, due to that complex plant constituent that is found in herbs, herbal formulas are often an ideal tool for mitigating various morphological forms of an organism, because we're also supporting the immune system as well as going after the organism. So it can be very, very helpful to kind of stay on top of that ability to have that organism change and morph into different forms. The immune system itself can start monitoring, and that's really what we're after in many of these formulas. MCBB1 may be supportive for those dealing with Lyme Borrelia, as well as MCBB2 may be supportive for those dealing with tick-borne relapsing fevers. We're seeing so much Babesia or Bartonella. Yeah, what am I saying? Borrelia miyamotoi, and it's amazing that we definitely need more tools for some of these things. So very, very helpful. Bar 1, Bar 2, and Bar 3 were created to support those dealing with symptoms associated with Bartonella. Bartonella is often one of the most challenging organisms to address, so we really encourage with these formulas to use strong detoxification and drainage support before starting these formulas. Working with them concurrently is really necessary and can eliminate a lot of symptoms, but also eliminate that the detox that comes about as a result. So it makes you feel a whole lot more comfortable. And I think this is back to you.
And I am back. All right. So Babesia is, again, one of those organisms that we're finding clinically resistance to pharmaceuticals. Originally, we started to use, I'm talking many years ago, clindamycin and quinine, and that really didn't work well and was replaced by atovaquone, which is Mepron. Now we're finding Mepron resistance, especially to Urticoliae and to Duncani. And so now they're looking for tefenoquine and some other antimalarials. But again, there are published reports showing that botanicals can eradicate Babesia in culture systems, and not just one, but several different types of botanicals can be used for that. And I noticed that Susan's formulas always involve a blend. Also, the botanicals can be much better tolerated than these more aggressive anti-Babesia prescription medications. And if you are treating a patient with the pharmaceuticals, there's no reason why you can't add. In fact, I always encourage you add to the regimen the botanicals, because they're supportive. And as Susan mentioned, the support is not just for the organism, but also for the immune system as well. Next.
Okay, so in terms of Babesia, it is a common co-infection, as Dr. Burrascano mentioned, in those dealing with Lyme disease, and a very uncomfortable one as well. For those of us that have had Babesia in the past, it is definitely unpleasant, and being able to work with it is very, very helpful. It is a protozoan organism that impacts red blood cells. So to be able to work with formulas that are in a glycerin base, that actually the cell is very attracted to the glycerin, which is one reason why we use that to be able to reach some of these intracellular organisms. BAB1 or MCBAB1, MCBAB2, and MCBAB3 have been very supportive for those that deal with different types of Babesias. So each of the formulas is really intended to support specific types of Babesia. Over the course of treatment, some practitioners may use one or more of these formulas in a given patient. Many of the labs that do come back, unfortunately, will show multiple strains of Babesia, and certainly having the tools that are targeted in these areas is very, very helpful. There are a number of different additional support formulas. As Scott mentioned at the outset, we have over 50 formulas, I think 52 to date. I'm currently working on 3 more. We continually adding support in this area is really helpful. ENLMC was formulated to support the body's natural defenses against mycoplasma-like organisms. MCCH is a little more targeted support for the chlamydia family. MCREA is also an immunosupportive formula that can be helpful for those that cope with the challenges of rickettsia, ehrlichia, and anaplasma. As I mentioned, they're a little more targeted formulas and usually used later in a protocol from some of the more broad spectrum formulas that we've discussed. Also, biofilms. Unfortunately, some of these organisms do have the propensity to promote biofilm formations. So being able to work with biofilms can be very helpful. The key is to know when in a patient's protocol to be able to start working with biofilms. So it's necessary, as Dr. Burrascano mentioned, to clean up the terrain. So supporting detoxification as well as drainage is imperative. When you're going after organisms that are in the bloodstream, eventually you're going to need to work with biofilm formation. BFM and BFMP. PFMP is actually more of a pediatric type dose. Many times adults will start with this dose as well to go at a rate that the body can handle in terms of support. It incorporates Google, which is a substance we've used for many years as naturopaths to emulsify fats, so that fatty component to the biofilm can be broken through and then eliminated with some of the proteolytic enzymes that are found in this product. BFM1 is a stronger version of BFMP and is intended for use in adults, though many adults, as I mentioned, will start with BFMP and graduate to BFM1. Let's see. These formulas are intended to be used late in a protocol and for short durations. Typically 6 to 12 weeks, we see improvement in this area. Anything that I haven't covered? Continued support for detoxification and drainage, as well as any of the anticipated remaining microbial burden is essential when using these formulas. So it is not something that you would exclusively use by itself, but in the course of a protocol that would be still eliminating some of the infections that you are working with. In terms of layering or treatment order, this is going to vary person by person. However, that foundation of detoxification and drainage support is recommended for each and every person. That's essential. If there is environmental burdens, such as with mold or electromagnetic frequencies that sometimes they play off of, unfortunately, mold, environmental remediation is certainly important, and there is support available to be able to work with molds in the environment. This is something that should be considered and looked at, particularly with those that are dealing with chronic issues. It can be an absolute find for that person in working with their health. Very important. And then there's mast cell activation syndrome or disorder. Many patients that have had long-term exposures to molds, as well as many of the infections that we've spoken about today, will develop this histamine issue in their system. So this is something that should be worked with as well. Again, reducing inflammation and supporting that immune modulation, very, very important to be able to move a patient forward. Virus and retrovirus support. And sometimes, again, we need to work with that with a patient prior to working with some of the infections, parasites, as well as GI support, fungal or yeast. Candida is very common infection with those, again, with their body's ability becomes overwhelmed and they have an inability to be able to tackle many of these conditions that typically our immune system would regulate. And then there's Lyme and co-infection support, as well as working with biofilms. So this is just a basic recommendation. Perhaps your practitioners find that something is really needed to be a little bit different with your situation, unique to you. But this is a good guide, again, building that foundation on detoxification, drainage, and our environment, as well as reducing inflammation. For additional information, we do have our product guide and product usage guides that are available to licensed and certified healthcare practitioners only. We do work with them. The formulas are potent. They're meant to be. We do want them in hands that are really capable. And so some of the dosing guidelines that are provided through these product guides. Beyond Balance also has a number of trainings, as well as different support webinars like the webinar today, available to Beyond Balance practitioners. So for those that are practitioners that do wish to work with Beyond Balance, we'd certainly welcome that, and that information is available on our site as well. And I think that's it.
All right. So I think we're going to have Dr. B and Susan on here as we run through some questions. Again, I'm Scott. I work with Beyond Balance Practitioner Support, and very honored to moderate this session today. Dr. B, is there any link or connection between Lyme and Hodgkin's disease? Is it possible for Lyme to somehow mimic lymphoma?
Well, as I mentioned earlier, Lyme doesn't normally involve lymph glands to the point, at least clinically, where you see swollen glands. Of course, it does do other things to the lymph nodes. But when you see a patient with lymphadenopathy, in the world of tick-borne diseases, the first thing you think about is Bartonella, not Lyme. But again, you have to be very careful that you don't have a patient who has both Lyme and lymphoma. You want to be, very diligent about that. But yes, Bartonella itself can mimic lymphoma.
Can you clarify what you mean by big box labs? Are you referring to Quest or LabCorp, or are there other labs in the big box lab category?
What I mean to say is that large commercial labs use test kits. They don't make their own reagents. They don't make their own things for these types of tests. They buy commercial test kits. And they're made in America, they're made in Europe, there are a number of different ones that they use. Test kits, by definition, have to be FDA approved because it's a device that's being sold. FDA approval is a licensing procedure. It's not a quality control procedure. It's a licensing. And when FDA approval is given, the test has to be comparable to what they call a comparator. And in Lyme disease world, the comparator is Borrelia burgdorferi stricto, which is at tick strain B31. So anytime you have a large lab, and could be Quest, could be a hospital lab, it could be LabCorp and others, by and large, they use commercial test kits, which means you're only testing for one strain of one species of one organism. So that's kind of what I mean. Private labs such as IGeneX, they don't have to be FDA approved because their things are done in their own lab. They're not selling kits to someone else. So they don't need FDA approval. Their validation comes from CLIA and other lab validation services. So they don't have to be FDA approved, and therefore they can do more. They can do testing for different organisms, different strains, different species, co-infections, and so forth.
You mentioned connective tissues. Can Bartonella ever appear to be a cause of Dupuytren's contracture?
I'm not aware of that in the literature, but I would say I would not be surprised, because Bartonella can inflame, and it will inflame ligaments and tendons. All it takes when you have an inflamed ligament or a tendon is some kind of a trauma on top of that, and you can get local swelling and degradation. If you ever looked at ligaments and tendons under the microscope, they kind of look like a box of spaghetti. Everything's all lined up smooth and straight. When they're injured, it's natural for the collagen fibers to bunch up and cause large round knots and circles. And that's why physical therapy is done, to stretch things out and get things to grow straight again. When you have Dupuytren's, you don't really have the ability to stretch them the way you should. So a simple injury, holding a screwdriver or a broomstick or falling down, can result in the type of injury that, when Bartonella is present, can accelerate and cause a real problem. So, like I said, I can't prove it based on literature, but I can definitely see that happening.
There's a comment that someone's Babesia was detected in a blood smear several years after their tick bite. Question about Babesia: can it show up on a test again when it appeared to have been cured? And maybe I'll just broaden the question to say, should we be expecting complete eradication of vector-borne infections?
Well, there are many literature reports of people who were treated for Babesia and seemed to be asymptomatic, and then had something happen. Immune suppressive drug, for example, a course of steroids, a cancer therapy or something, was given, and Babesia came back. So it was hiding somewhere and regrew. In terms of a blood smear late in the illness picking it up, again, if you have a percentage of a pickup rate of like 1 in 200, sometimes you're lucky and you can find these things. But I'd much rather have a FISH test if you're looking for a smear. Now, that's a very good question. Do you cure tick-borne diseases? I don't know if that's necessary. I mean, it's always a balance between the strength and numbers of the pathogen versus the strength of the body's defenses. And once you pass that threshold where the defenses exceed the bacteria or the parasite, then it can remain in check and you can remain relatively well. But those are the people who, if some future insult happens, a very bad infection, an injury, a stress of some kind, or some immune suppressive treatment, then these things can come back. I've always said that in my patients, I never guaranteed them a cure. However, if they remained well without relapses or new tick bites for 3 years, then in my experience, they've never relapsed. So 3 years is my window, but that's just me.
A couple of questions about fish testing. Why is there no fish for the Borrelia organism? And then related to biofilms, which tissues can be used to do a fish? Can we do more than just a blood sample?
FISH is a test that was developed for the blood. Can be probably used on tissue fluids as well, but it all depends on where the organism tends to hide. Lyme organisms are difficult to detect on fish simply because they are so few in number in the bloodstream. And when they are in the bloodstream, their passage is intermittent. They can be there sometimes and not. And I remember years ago, back, I guess it was in the late 1980s, I worked with Alan McDonald on his culturing. And the only time we could get positive cultures in a Lyme patient was when they were drawn in the late afternoon or mid to late afternoon. Most Lyme people by 2 or 3 in the afternoon, they feel like their energy just sags and they feel poorly, maybe some flushed, maybe that's when they have a low-grade fever. That was the very best time to pick up the culture. But if the culture were done at different times of day, we'd had a hard time picking it up. Nowadays, IGeneX culture is much more sensitive and much more specific, so I don't think that applies. But just to say that Lyme is a kind of a sneaky thing. It comes and goes in the bloodstream in a pattern that may not always be obvious. So the fish testing can be done, but the yield is not high enough to make it worthwhile.
And did you comment on why there's not a fish test for Borrelia?
Yep, that's what I was just saying.
Okay, awesome. Let's see, there's a question, cherry angiomas, Bartonella or Babesia?
I was told years ago that they relate to Babesia. However, we know that Bartonella does things to the blood vessel. It lives in blood vessels that causes angiogenesis and a number of other things. You can actually measure the vascular endothelial growth factor in patients, and in some Bartonella cases, it does increase, and that is why you can get vascular proliferation. But there are people who don't have tick-borne diseases who have these berries, so I don't really know. I would love to know. What I think we should do is find some people who have this and do some biopsies and look for what's in them.
So we're going to jump back and forth between Susan and Dr. Burrascano. Susan, can Beyond Balance products be purchased without a prescription?
Well, the short answer to that is no. They really need to be purchased through a practitioner that has an account with Beyond Balance, and there's a reason for that. These are not to be used as pharmaceuticals, but at the same time, they are potent. And as I mentioned, we do want them in the hands of practitioners that have some training.
There's a question about the specific herbs that are found in the Borrelia and Babesia support formulas. I think if people go to the website, they can find that detail.
Yes.
Can you tell us about the Beyond Balance products for mold toxicity?
Mm-hmm. Yeah, there are several products that we use in this area. Pro-myco is probably the first line of defense that we would use in a person that is still living in a moldy environment and needs some support right away. This is heavier on detoxification type of support and little on actually going right after the mycotoxin or the mold, rather, the mold spores themselves. Also, there's two other formulas. One is called ENLBT1, which has overlapping benefits to working with fungus as well. And then our formula mycorrhigion, which Dr. Neil Nathan mentions in his book Toxic, in regards to some more potent support in mold illness as well.
There's a question that sounds like this is from a practitioner. I'd love to see a practitioner guide that details the finer points of differentiating these similar sounding formulas. Something in print would be very useful. I've been intimidated to dive into the Beyond Balance family because my perception is that it takes hours and hours of training to become familiar with them. So we do have a product guide that's available for practitioners. It doesn't necessarily differentiate to the same level of detail that the practitioner training does, but you're more than welcome to contact us through practitioner support. And we can also do one-on-one conversations with practitioners to go into more details if you don't have the time to attend the full training. Susan, any plans for Beyond Balance to be available through Fullscript?
Not at this time. The issue with that is we lose connection to the practitioner and their ability to be able to get the kind of education that's needed and being able to use the formulas effectively in protocols. So that's really the reason that we don't use Fullscript for that purpose. I understand that kind of having that one-stop shop type support can be very, very helpful for the patient, but it is not, it's really a mixed bag of being able to work with the practitioner and supporting their educational process as well.
Question for Dr. B. How common is chronic anaplasma?
The dogma, if you believe in dogmas, which of course we don't, the dogma is that there is no such thing, but I have seen it over and over again. And with a really powerful culture that IGeneX now has, they are culturing anaplasma from patients who've been chronically sick for months to years. So there is such a thing, definitely, definitely.
Can I be infected if the tick was on me less than 24 hours and was ripped while removing?
Wow, what a topic. Let me start at the very beginning. First of all, studies of tick transmission to humans are based on tick transmission, or I should say pathogen transmission through tick bites in animals. Some animals, including rabbits, that don't even get the same kind of tick bites that humans do, and other animals. So The dogma has then been 24, 36 hours and so forth. But we've all seen transmission more quickly than that. And there are actually publications where transmission was documented in 5 hours or less. Now, that's for Lyme Borrelia. I didn't have time to go through the details of tick-borne relapsing fever, but some of the relapsing fevers are transmitted by soft ticks, which do exist in the southern parts of the United States and some other areas, and central United States as well. And transmission, are you ready for this? Can be as quickly as 15 seconds. The soft ticks only bite and hang on for 5 minutes to half an hour, and then they drop off. Again, a painless bite. Usually don't give a rash, don't make it itchy. But within 15 seconds, it's been proven in published papers, it can be transmitted. So if tick-borne relapsing fever can mimic Lyme, which obviously it can, as you see from today's presentation, and it can be transmitted in seconds or minutes, then absolutely 24 hours is not at all a hard cutoff for getting sick.
What IGeneX testing can be used for a breast biopsy tissue?
Definitely the culture, the CE-PCR.
And maybe could you talk a little bit, there's a related question here about for any of the IGeneX testing, but I think also specific to the culture, do you need to stop anything before doing any of these tests? Do we need to consider stopping antimicrobials, for example, to optimize the test results?
Well, first, I would never recommend you stop needed medication just for the sake of getting a testing done. If you have a test which requires someone to be off treatment, then all right, if they are taking a medication break or if they haven't been treated for a while, then that would be to do it. Now, specifically, tests that are indirect, the antibody tests like immunoblots and the T cell reactivity test, they're not affected by the antibiotics. In fact, in some early disease, treatment can actually make them more likely to be positive. With a direct test like culture and fish, because you're looking for organisms, if you're on a regimen that is knocking down the burden of pathogen, then the test becomes less sensitive. But again, it all depends on the patient. If they're on treatment and they're having terrible fevers and sweats and they're obviously terribly sick, then a direct test could pick it up as well. And we've seen that. A general rule is that you try and be off treatment for several weeks before you do a direct test. But it's not a hard and fast rule. Just don't stop treatment for the sake of a test. It's not good medicine.
Susan, question for you. Is it possible to use both the Beyond Balance products in conjunction with bee venom therapy or with antibiotics or other supplements during the treatment of Lyme and co-infections?
Absolutely. There's many practitioners that are using combinations of many different, not only supplements, bee venom therapy is mentioned there, antibiotics. Again, it's the education part of knowing exactly what you're doing and you're not driving the immune system to respond so that it becomes upregulated or a tremendous amount of inflammation ensues. So it is, really knowing what you're doing in terms of working with the body and that natural process that is necessary to help a person move forward and heal.
Dr. Burrascano, for anaplasmosis, if a patient shows a low or negative IgG and positive IgM on a typical Quest lab and also had anaplasmosis 2 years prior based on a positive IgM, what would the recommended course of action and testing be today?
You would want to try and confirm that with a more reliable test, such as what is available at IGeneX. If you're thinking about a persisting infection, that's a perfect time to do a culture because that would pick up whether the organism is present or not. IFAs, as I mentioned before, are not high technology tests. They were the first serologies ever developed back in the day, and they can be prone to false positives, especially IgM. They can cross-react to a number of DNA viruses, such as Epstein-Barr, herpes type 6, and so forth. So knowing that, a better workup is in order for the reactivation of viruses, for example, as well as for autoimmune disease. And then doing a more specific test, and IGeneX IFA is better. And then, of course, the culture.
So we're probably going to go just about 5 more minutes and then we'll wrap up. Another question for Dr. Burrascano. I sent in a tick for testing at IGeneX this week. If the results are positive, does this negate the need for testing the patient who has developed acute Lyme symptoms?
I hate to tell you, but I think, in my opinion anyway, I don't think tick testing is that accurate. Um, again, I've been around a long time and I've spoken to, the Willy Bergdorfers of the world, and we've talked about a lot of things that never get published. And he also did not like tick testing because he said sometimes the organisms, including Borrelia, are present on the surface of the tick and may not have been transmitted. So you can get false positives from that point of view. Likewise, testing the tick uses technology that is never 100%. No tick testing is 100%. So it's possible to miss things. So the fact that there was a tick bite and the fact that at least one of the pathogens showed up and the fact that the person is ill means you have to be a clinician. Go through the symptoms using the guide that I gave you and others and try and pinpoint what you think is going on and then get some more specific testing on the patient. And don't just rely on the tick itself.
If finances are an issue, and they almost always are, which would you prioritize for Bartonella, a fish or an IGeneX spot? And then for Babesia, would you prioritize a fish or a PCR? Or maybe you'd prioritize something else?
It's a subtle question. I don't know if you understand what I mean by that. It depends on the presentation of the patient. If someone has very active symptoms, for example, with Babesia, having sweats and so forth, you have to think that there's a lot of parasite in the circulation, and then a direct test, such as a fish or culture, would be the way to go. If someone has lower grade symptoms and they've been through treatment in the past and they're not terribly sick, but they're not terribly well either, then I think an antibody-based test like an immunoblot would be the way to go. So it's not that one test is better than another. It depends on the specific situation. And you think about it, all right, is there something running around the blood right now and the person's deathly ill? Let's do a direct test and look and see what's going on. Or is it one of those chronic things that's been happening and it's been through treatment and want to see what the status is? Well, that would be more an immunoblot or T-cell type of a test, or both.
Susan, how quickly can MASTs start working?
Very quickly. I've seen it work, well, at least help and support that histamine response within a matter of days. Typically this has been a chronic situation for a person that suffers from mast cell activation. So, I don't think that it's something that will just clear up very quickly, but does it improve? Absolutely. Yeah.
And I think maybe the other thing to add with that is when you're using something like MASTs at the same time using that symptomatically, we want to work through all of the triggers of the mast cell activation that Susan and Dr. Burrascano talked about earlier: infections, mold exposure, parasites, EMFs, those types of things. Another question here, Susan, could you expand on why the biofilm formulas are only intended for a short duration?
Yeah, I mean, typically they are quite potent, and we see biofilms clear in testing. So is it necessary to continue? Not really. So I think that's probably the most direct answer to that question. We want to see the biofilm activity clear from the system.
I want to chime in a little bit also.
Sure.
One of the reasons why we tend to use biofilm busters later on in the course is because they do harbor a lot of pathogens and a lot of antigens, not just the pathogen itself, but their bioproducts, free DNA, toxins. They harbor viruses, and it's been shown that this can be a virus nest for Epstein-Barr, for example. And so if you have someone who's not prepared, whose terrain has not been stabilized, who's not been detoxified, whose immune system's not been supported, and you break up biofilms with something potent like these formulas, they're going to get much more sick. So we really leave that to the end to do the final cleanup.
I say amen to that.
There's a question on treating for mycoplasma. I think Susan touched on that in her presentation. There is a product called ENLMC that can be supported for mycoplasma, as well as the BB1, BB2 products. So those would be potential options. Let's see, there's a question about why Bartonella affects the GI tract so much more than Lyme and other co-infections. Dr. Burrascano, any thoughts?
It has to be with the local microenvironment that favors the Bartonella. They've done the publications that show, for example, children who have chronic GI issues They were biopsied and PCRs were done, and the number one pathogen was actually Bartonella, and H. pylori was number 2, and Borrelia Lyme was number 3. So there's something about the microenvironment that favors the Bartonella to harbor that, to be harbored in that area. Other than that, I can't give you specifics. Interestingly, published decades ago was that when you treat Bartonella in a patient with GI issues, they recommend you add a proton pump inhibitor to enhance the effect on the GI tract.
You touched on this a little bit in your presentation, Dr. Burrascano. People are interested in how quickly you can test after getting a tick bite, and it's going to be different based on the type of testing. But can you maybe tell us which tests are going to be still reasonable to do early versus those that maybe we should wait until much later?
The direct testing can be done pretty early. Perfect example is babesiosis. Acutely, the parasite load is high enough that you can just see it on a direct blood smear. Often labs do a blood count and differential count to look at the basic blood smear, and they see, oh, there's something floating around. So direct testing is useful early on in the infection. For indirect testing, and meaning the serologies, the antibody testing, immunoblots have been shown to start to pick up infections as early as 2 weeks after the infection has started. Their peak sensitivity actually occurs, I showed you 93% of the time within the first. Well, those are CDC samples, and CDC's early Lyme is at the formation of a rash, which is usually 2 to 4 weeks into it. And again, it picked up 93%. So that's actually pretty good.
Awesome. All right, so just a couple of wrap-up comments. So the recording, I believe, on the IGeneX site will be up later this week. We'll have it up on the Beyond Balance site shortly as well, probably next week. I believe the slides will be available in PDF format for you there as well. I want to thank Dr. Burrascano for his amazing presentation. I want to thank Susan for her amazing contributions to this presentation as well. I would just really think that this was a fantastic time. I appreciate everyone joining. Sorry that we didn't get to all the questions, but if you still have questions, please do reach out to either IGeneX or Beyond Balance, depending on your question. And thank you so much, everyone, for joining us. And we look forward to connecting with you again in the future. Be well. Take care.
Good night, all.
Everybody.